Welcome to the NOCC's 2024 Fall Wellness Symposium, Hope in Hospice. I'd like to take a moment to sincerely thank our symposium sponsors who are dedicated to providing learning opportunities and programming for our teal community. Thank you so much first to Northwell Health and to GSK, AstraZeneca, Merck, Veristem, and Asai. My name is Stephanie Taylor, and I am the Senior Manager of Programs and Community Engagement for the National Ovarian Cancer Coalition. This symposium was created to provide you with much needed guidance and clarification on the very sensitive subject matter of hospice care. I'm pleased to welcome two experts this evening, Valerie Berger, Assistant Vice President from Northwell Health Cancer Service Line for the Eastern Region, and Dr. Tara Liberman, Executive Director for the Hospice Care Network, also with Northwell Health. Thank you both so much for being here as we address once again this very important and yet extremely sensitive topic. Valerie and Dr. Liberman, we're so glad to have you, and I'll turn it over to you now, Val.
Thanks so much, Stephanie. We love to work with the teal community, and I know that I've done a few of these before, and it's a great opportunity for us to help you understand all the things that we have available within healthcare. And I think hospice is one of them. And it can be really scary. It can be kind of scary. It's a scary word, and it means something to a lot of people, and we want to help sort of get rid of some of those misconceptions and hopefully make it a little bit less scary by clarifying some things. I know that Dr. Liberman, who I think, is it okay if I call you Tara?
Sure.
Okay.
Love that.
Because we've worked together and we've done, I think when you work in hospice, it's a very intimate look at patients and families. And you have to learn to rely on each other as people and not so much as the doctor, the nurse. I'm a registered nurse. I've been a registered nurse in hospice, and I know it's the team. And we're going to talk a little bit about what that team looks like. But so let's start off with, can you tell us what hospice is and how maybe it's different from palliative care? Because I think we hear those two things and they get confused a lot of times.
Yeah. So again, thank you all so much for letting me be part of this today. And it's wonderful to see Val. We've worked together for so many years, and having this conversation with you is so meaningful because we have done so many projects on how we can educate and inform the community about what this exactly is. What is palliative care and what is hospice care and how do they intertwine with each other? So I guess the general thing is that palliative care is a care for our patients when they have a life-limiting illness. And it could be at any time during their journey, when they're first diagnosed, in the middle of their care, or at the end of their care. And that could be for many years, weeks, months, it does not matter. And that's about how do we improve the quality of their patient's life when they have a life-limiting illness. That means they might have some issues with anxiety, shortness of breath, pain, and that would be professionals who'd be able to work collaboratively with their primary caregiver team to be able to support them through that issues. Hospice care encompasses palliative care, and those are for patients doing a similar treatment, but only for patients who we think may have less than 6 months to live. And that's the benefit that they're provided, and they're able to have that be cared for in their home by an interdisciplinary team, again, working collaboratively with their primary team, but more specifically in their home, coming to them to care for them and helping them support them.
Do I have to have Medicare to be able to have hospice?
No. So many states have hospices that are non-for-profit. So you can get hospice care without any insurance. The majority of patients in the United States who are getting hospice care are Medicare beneficiaries. We have about 93% on our program that are Medicare beneficiaries. But you can also have private insurance. And again, like I said, or Medicaid. but you also don't have to have insurance at all if you can find a hospice that's not-for-profit, like we are.
So what does it cover? What are you entitled to when you sort of activate that hospice benefit? Or maybe before we answer that, so palliative care is that sort of symptom management, right? And hospice care is when you can predict the death of someone.
And we're all not able to have a crystal ball, right? And it's really, if a physician or an NP or a provider or even themselves are thinking, it wouldn't be surprising to me if I pass away in the next 6 months, this would be a great benefit to help support them. We have many patients that live past that. Look at Jimmy Carter. He's been on hospice for over a year and he's thriving. And he's had great support. It's really, it encompasses in their home and brings patients the support that they need. Palliative care is usually, it can be in the home too, but majority of the time it's more like traditional outpatient practice or in a hospital where the providers that are sort of supporting the team that is primarily caring for them. And they're focusing on things like symptom management and maybe some psychosocial support as well.
They're both about quality of life, though.
100%, and they're both amazing programs. It just depends on where you are in the program of your disease.
And they overlap because they do some of the same things, but hospice is different. So how is hospice different, and what is someone entitled to when they're on hospice?
So hospice, in essence, is usually a home care benefit. Most patients who are on hospice are at their home. And what they can get is actually a lot of great support. If they need a hospital bed or any medical equipment, we can provide that to them through their insurance benefit, nothing extra cost. So if they need a hospital bed, a wheelchair, a walker, anything that they might need to help improve their quality of life, we could provide. A nurse comes at least once a week, maybe more often if necessary, to make sure that their symptoms are well controlled and that they have all the things they need. They also can get their medications. We send them to their home. We provide that through this benefit as well. And any other tests that they might need also comes through it. And then they get a team that's amazing. Social worker, a nurse, a chaplain, volunteer, a physician if needed. It's quite amazing at all the people that you have at your fingertips that can help you and your family understand how they could be best utilized and cared for during this time in their disease process.
So I have 2 questions.
Sure.
Can I be on chemotherapy?
Unfortunately, no. And that's
why not?
Because the essence of hospice is that it's when patients have decided that their goal is to focus on comfort and to extend their life with comfort, but not with life-sustaining treatments like chemotherapy. So that limits us for things like chemotherapy.
So it's about allowing the natural process of a disease or the natural process of all of our lives, because we are all going to die at some point. The people who are on hospice, it's just more predictable.
Usually. I mean, I think that there's a spectrum of patients who are on hospice. Some we can easily predict and some we can't. And that's okay.
Because it's all about comfort and quality.
Correct. And it's all about the support of the patient and their family.
Right. So patient and their family, that's good. So my second question was, you said there's a great big team. They come to my house and stay with me?
No. That's always the joke. We have our nurses who will go out, and we've had patients actually say, we've made a room up for you, come and sit down. Unfortunately, it's not a live-in service. It's a home care benefit. So the nurses and the social worker and the chaplains, they come to visit on a basis of when needed. Obviously, the nurses come on a more regular basis, but the others are on a when needed basis.
Regular being weekly or bi-weekly.
Correct. Yeah.
Okay.
Mm-hmm. And there's also that opportunity for support through an aide. We look to help supply if somebody needs some support with bathing or dressing, or creating a meal. If we're able to, we would like to bring them into the home to support the patient and their family in that. Unfortunately, that is also not a 24-hour service because it just isn't, they don't exist, to be honest with you. We have a national shortage of hospice aides in general. So we try to do our best to give them as much possible time as we can.
And who then helps take care of the person who may be so ill that they can't get out of bed?
So we look to the family or the loved ones that can support the patient during this time. It's a difficult time, but it's also a meaningful time. I think that people who are able to be with their loved one are able to support them and feel that they've done what they can for their loved one. If they're not, we also have social workers who can help support them in figuring out what would be a better alternative to them being in their home, right? So they might need to be in an assisted living, and you need to be in a nursing home, and we can bring hospice to them in those places. So it's not all about always having to be in one's actual home. It could be a home-like setting, and it may not be their specific home.
Sounds like it's hard.
It's hard.
There's a burden on the caregiver, on the family.
Yeah.
And so are there supports from the team for the family?
I have to say that that's the part that we say over and over again. Without us, that this is happening, right? Patients and families are taking care of their loved ones and struggling. When we come in, we bring that extra layer of support. If we weren't there, they would never have gotten that. So this isn't gonna not happen. Unfortunately, it's going to happen. Someone's gonna need support, care provided. It's a question of whether it's alone or with a service. And so we come in and support that. And we bring the nurse and the social workers sort of provide that care, not only to the patient, but to their family as well. And a lot of this is, how do they handle the day-to-day work? How do they get meals? Maybe they need someone to go out for them. We have volunteers who will go shopping for them. Maybe they need someone to sit with them while they go out shopping. We'll bring a volunteer to do that. We try to be creative in ways of making sure that they could do the best that they can to support their loved one while they're at home.
So there really is a whole team. There's a social worker, there's a doctor, there's a nurse, there's a social worker, there's a chaplain, there are aides, there are volunteers. All of those people come in episodically, but support a patient and a family during this challenging time.
Yeah. And the nice part about this is you're not even alone in the middle of the night. We're available 24/7, and someone who will actually pick up the phone and answer it by a voice and be able to work with you and talk to you about what they're seeing and what they're concerned about. And if need be, even send somebody out in the middle of the night to help support them. The ultimate goal is so that they don't have to end up back in an emergency room. Emergency rooms become burdensome, especially as we get more frail and have more symptoms. And our goal is to do the best we can to keep them out of that environment.
They're so impersonal. So that goes back to really utilizing hospice helps keep things personal, calm, controlled, about comfort, and about quality.
Those are the things that we strive for every day.
Yeah. So who is a part of that decision-making process? How do I make that decision? How do I get there?
So everybody's different. Everyone's journey to hospice is different. Sometimes it's the provider who may say to the patient and or their family, I think it might be an opportunity for you to be utilizing hospice at this time. It's part of your disease trajectory. Sometimes it could be a family member who is watching the treatment causing more harm or making people sicker and thinking maybe my loved one would be better off utilizing hospice and taking a break. And sometimes it might be the patient who says, it's time for me to be on hospice because I want to be more comfortable. I want to stay home and I want to be able to get the support I needed and my family to get the support that they need. So we see this come from many different places. And none of them are wrong and or right. They're all just what's personalized for that patient and family.
So do I have to give up my doctor?
No. And in fact, we encourage everyone to keep their doctor. we want to be a part of the journey with that care team and you. It's important that that stays in place because they know them best. They know the history. They know what has gone on. They know the dynamics. And for us to just be an extra layer of support is really helpful. There are times, though, that the team that has been caring for you may feel that they can't be the best provider, and sometimes we'll step away or allow for the medical director from hospice to sort of be the more of the driver of the care because they are able to sort of focus a bit more on like symptom management that maybe their primary team wasn't able to do. But in essence, we always try to partner and be a part of the team that they've always been a part of.
So I can keep my doctor and add hospice and the medical professionals at hospice as an added layer, as like super consultants in my care.
Yeah.
But my doctor may not feel equipped to do that. So then he may turn over my care, he or she may turn over my care to the medical staff at hospice. That's how it works.
We see that a lot, and I can understand that. I mean, sometimes these can be complex. Symptom management, psychosocial support, spiritual support may not be what they're equipped to be able to handle on a day-to-day basis. And so that's why we are, as the experts, are here to help the patient and the family be able to support them through these needs. Mm-hmm. But if able to, we would like to keep the primary team, so at least they're apprised of what's happening.
So when do I start? When do I know that it's the right time?
So I guess that's a conversation that one would have with their providers. They would also have that conversation with themselves and with the people that are surrounding them, their family and friends. And those are hard conversations. And sometimes there are people that might be easier to talk to and some that may not. And that's all individualized.
So how do I get to you? Who can call you? Who can reach out? How do I access hospice care?
So in each state, there are hospices. Some have many, some have less. It's sometimes easy to ask your provider if there's a hospice that they utilize that has a good reputation and they'd like to work with. It's sometimes just as easy as looking on the internet or and calling up and asking about the services they provide. And that can come from the patient and the family, and it doesn't always have to come from the provider. Sometimes our providers have a hard time having this conversation. Just as we're having a hard time conversation, they have a hard time having this conversation.
I think, we live in a society, certainly here in the United States, and our culture is one that, medicine has to be successful. Medicine has to help us live forever. Medicine is a failure if someone dies. And then it's a failure all the time because we all will die. And I think it's important to realize that there's a way to die with dignity and comfort and quality. And hospice allows us to do that. But it's about having that conversation. And it's about having your needs known. So we talked about, I can't be on chemotherapy. You have to give up those curative things. Do I have to give up all of my medications? What if I'm in pain? What if I have symptoms?
No. And in fact, we utilize most of our medications, whatever you're taking on a regular basis. If you're somebody who has high blood pressure and on top of your cancer, we're not stopping your high blood pressure medicines. We're not stopping, the day that their hypothyroid medications. Like, we want to make sure that you continue your good quality of life. And so those things are not stopping. We're providing medications that may enhance your symptom control, like medications like morphine or morphine derivatives. There might also be things for anxiety, things that like Xanax, Ativan. You might have issues with shortness of breath. Sometimes we use opioids for that. We provide oxygen in the home. That's something that people struggle to get. And we provide that as well. And so there are just a lot of things that we can bring to help you. I think people also always get concerned, like, well, what happens if I get pneumonia? Am I allowed to get antibiotics? The answer is yes, if that's appropriate and that's something you're interested in, if that's going to make you feel better by getting antibiotics to help your pneumonia, we're going to provide it to you as well. So I think that people get concerned that once they get on hospice, everything is stopped, and that's not the case at all.
All right. I think we talked about who's on the team, and the social workers provide a lot of support along with the chaplains, I think. Do they help families as well, or only patients?
No, and a lot of our care is about not just the patient, but the caregivers. And we talk a lot about caregivers. We try our very best to provide emotional and spiritual support for them as well. If there are children involved, we have specialists who handle the psychosocial and emotional and spiritual ways that children might be affected, or grandparents, parents of people. It comes through generations, and there's not just the patient in the room, but the caregivers as well. So we always try to figure that out.
So I've heard about something called respite care.
Mm-hmm.
Is there support for things like respite care?
Yeah. So, I mean, I think that, as you mentioned, that this is really hard and that it can be a burden. And life happens for people. Let's say you have a wedding that you need to be in and you can't leave your loved one alone. We have the opportunity to provide, 24-hour respite care up to 5 days for a patient to go to a facility where your hospice has contracted with, in order for them to be cared for while you can do the things you need to do. We had a lot of patients during COVID who had the height of COVID that would get COVID and they couldn't have their loved one in the home. So we would provide respite care for them for those 5 days while they were trying to recover. So lots of different ways and reasonings for why sometimes this time needs to be utilized as well. Maybe just for some, overburden. They need some time to be able to let their loved one be someplace else, and they could take that time, refresh themselves. Maybe they need to get their home health aide in the house for 24 hours. So there's lots of reasons why we can provide respite care.
All right, so now I'm going to ask a question. If you can provide care for 5 days, why can't I go somewhere? Why do I have to be at home?
So Medicare has a very high, and all the insurances really look at the strict regulations around what does hospice look like. And inpatient hospice, which is what most people think of as, well, I'm going to hospice, which is a building or a place, is not the reality. Most patients, like I said, 97-8% of patients who are on hospice are in their homes. Those inpatient facilities are really for when patients have acute symptoms that can't be managed at home. Things like acute pain, acute shortness of breath, acute nausea and vomiting, maybe a very extensive wound that needs multiple times a day dressing changes. And those are for very short periods of time. And then the goal by that insurance company is to sort of get them back to their home. Unfortunately, a lot of times patients do pass away in those inpatient facilities, but yet that's what the essence of an inpatient facility is really for short-term emergency care.
So again, comfort, symptom management, and the need for more than what can be delivered at home.
Correct. And that's what they're looking for.
So hospice care really is something that happens at home.
Majority of it.
What if I live alone?
That's okay. You can live alone. And actually, that's a great opportunity for us to bring our multidisciplinary team in to sort of understand how we can provide support for you while you're at home, keep you independent as long as you possibly can, but have a plan for when you can't be independent. This is an opportunity for you not to end up in a hospital and be there at the end of life, but to find a way that somewhere else or bringing other people in to support you can be an option. And we do that a lot. We do see that a lot. As we're getting older, as a country, people are living longer, and their spouses are passing away, and they're by themselves. So we see this quite often, and so that's something that we hope that we can help and provide support through this journey without having crisis management.
So we want to avoid that crisis. how do we avoid that crisis? How do you avoid getting caught with your pants down? Sort of how can we not get stuck there?
Having these conversations early. I think that we as a society have a hard time talking about what the future looks like because we're always so present in the current state. But we need to prepare. And if we could have open and honest conversations with ourselves, with our caregivers, our loved ones, our providers,
our friends,
people in the community, our spiritual support, we can provide resources to them so that they like hospice, so that we don't end up in crisis. And what we find is that we are being called too late and that we end up in patients' crises. Our length of stay is less than a week, which is really, a hard thing to do. We have to come in, we have to meet people, we have to provide all the medications, and it's almost as if we've become a crisis management team.
And yet the benefit is available up to 6 months out.
Correct. When we have patients on for a longer period of time, they seem to improve, have better quality of life, have a better end of life process. And so that's why we encourage people to join us and be a part of us sooner than later.
So what happens if I improve? What happens if I go on to hospice? You do such a great job of managing my symptoms that I actually feel better and have a better quality of life and better outcomes. What happens then?
We say goodbye to hospice for the time being. And we see that a lot. A lot of people who come off their chemotherapies and take a break and come on hospice, we see patients feel better and improve their function and their appetite. And they sometimes decide that they want to return to some of those treatment options. And we say, please go ahead and do that. They revoke hospice. And then if at any time during the future, we're back to support them all over again. So it's a fluid service, and we would never stop anybody from wanting to do what they're entitled to.
So it's not limited. I can't only do it once. I can't only make that decision. And so I can come on, I can go off, I can come back on.
Many times.
And I've seen that too, in that, you do such a good job of helping people with their quality and people with their comfort that they do get better. The disease is still there. The illness is still there, but people manage it better. When you have a heavy burden of symptoms, it really makes everything bleak. But when those symptoms are managed, I think life progresses longer.
And we have seen that, and even in studies where patients have involved palliative care or hospice care, and they've lived longer in spite of the opportunity for some treatments like chemotherapy, sometimes that has shortened their life.
So the things we've learned is hospice is about comfort and quality. It overlaps with palliative care, but it's different. It happens at home. Caregivers at home are supported by the team. I can keep my doctor if my doctor wants to be a part of the care team, or he can be apprised by the hospice team. I don't have to give up my regular medications. I can come on and off. I have the opportunity to have respite for my caregivers. And then it's about having those honest conversations. So what is it when we talk about advanced care planning or healthcare proxies or MOLST forms? What purpose do they serve?
So those are documents that are really important for you to fill out when you are unable to make those decisions for yourself. So these are ability for you to make your wishes known through documentations. A healthcare proxy is someone you appoint who knows your wishes for them to speak for you only when you cannot speak for yourself. An example would be if you went in for surgery and there was a decision that needed to be made. You would have hoped that you would have filled out a healthcare proxy ahead of time and had those honest conversations about what's important to you so that they could be guiding those providers about what to do next.
So does my healthcare proxy have to be my husband or my daughter, or, who does it have to be?
It's the person who you trust most to make decisions on your behalf in the way that you would want to be told your story.
So that healthcare proxy is not making decisions, but they're carrying out my wishes.
Correct. It's your voice. They're your voice.
So it's somebody that I have to have had a conversation with, those honest conversations about what's important to me.
Right. Correct. And all too often I see people just fill out healthcare proxies with lawyers and never tell them that they're their healthcare proxy. And then they're like, what happened? So I really encourage every patient of mine, no matter what age they are, to sit down with their provider and say, I'd like to fill out a healthcare proxy. This is who it is. Please keep this on your record. And I'm going to keep one for myself as well, and have it available for anyone if they so need to. And then providing it to the person you have designated as healthcare proxy, so that they know they're a healthcare proxy.
Right.
Because again, we've also had that experience.
And to keep it updated, because there have been times, I know in my experience, where perhaps your husband was your healthcare proxy. Maybe you got divorced, you didn't change that paper. It can get sticky.
Correct.
So that's one thing, a healthcare proxy. But then what is a MOST?
So a MOST is a medical orders for life-sustaining treatment. And some states are called a POST, the physician orders for life-sustaining treatment. And basically it's a form that pretty much tells your wishes for when you get very close to end of life. So it's those things that might be talking about how you would want to live if you were to die. Do you want to be resuscitated? Do you want to be on a machine that helps you breathe? Do you want someone to do CPR? Would you want dialysis? These are very important questions, because some people would say, yes, doc, I would like to be in an ICU. I want to be on a ventilator. Please keep me that way. And others would say, doc, I would never want that. And I want to be comfortable. I want to be in my home, and I don't want anyone to do any of those procedures. Everyone has a different opinion. And it's really important that your opinion is documented, especially when you're getting closer to the end of life, because you don't want people to do things that you don't want happen to you.
So again, it's about your voice being heard.
Yeah.
So a healthcare proxy can speak for you because you've spoken to them. And the MOST or the POST is sort of the doctor's orders for what should or shouldn't be done.
Correct.
Like, I want antibiotics, but I don't want to be on a respirator.
I want fluid,
but I don't want a G tube.
Correct. A tube to help feed me.
Right. Because there may be a need for a G tube for other medical reasons. So you have to be specific.
Correct. And this is why you have this conversation.
Right. Right there. There it is. Yeah. Okay. All right. You know what? I've heard about death doulas. I've never met one. I mean, I've never worked with one. Can you tell me about them?
So death doulas are individuals who have an expertise in helping patients and families at the very end of life, when somebody is in the active dying process, and they could be a part of the journey through that process. They're usually with them at bedside. They're usually making sure that their symptoms are all managed and comfortable. Some hospices have death doulas. Ours do not. Although I feel like my staff is a death doula. Our nurses are so wonderful at providing that support. Our social workers, our chaplains, they do at times sit there and are with them through the last process. And so that's pretty much what a death doula is. It's almost like a birthing doula, helping someone bring someone into life. They're sort of bringing someone into their next journey.
So can it be that predictable that you know when it's going to happen?
Everyone's different. And I'd love to say that we had that crystal ball, right? That we could say, you know, my loved one's going to pass away tomorrow. Sometimes I see patients live for months that I thought would pass away tomorrow. And other times they pass away suddenly and I would have never expected it. So that's why it's so important to be prepared and have these conversations so that if things change, which could happen at any moment, we are able to bring that patient and family through that journey in a meaningful way.
It's a special time, isn't it?
Mm-hmm. It's a meaningful time.
And it's important that it goes well.
It's very important. Just as you would hope that your birth of your child went well, you would hope that the loved one's death was just as peaceful and calm.
I think for me, it's a privilege to be able to work with people who may have a life-limiting disease. And it's an opportunity to help provide comfort. I think that's one of the main reasons why I went into nursing, because I wanted to provide comfort. When I was a young nurse, I hated to do things that made people hurt. So I would trade tasks with someone so that they could give an injection for me. But being able to be with people and families and have the privilege of becoming a part of that sort of death surround story, because we all have those stories, and we know that people like to tell those stories because it helps them process that grief. And for me, being a part of hospice and having worked in hospice the short time that I did, it was lovely to be able to help write that story with people. And that's why I believe that hospice is something that everybody should know about. And it was why it was so important for me to be a part of this education tonight, because as we started out saying, is that it's an underutilized part of our medical team. It doesn't have a very long history. I mean, it hasn't been around for very long. It started in England, and it's not well known and well understood. So I hope we've answered some questions tonight. I think we'll be happy to answer more if there are any, but I mean, do you have any thoughts about how did you come to do this?
I mean, I think I have a similar experience in that I went into healthcare to help people. And I think during my journey in my medical training, I found myself being frustrated by doing procedures and giving people treatment that wasn't going to improve their quality of life. It wasn't going to extend their life. It was just because we could. And it's gray. It's not black and white. And most physicians are not very comfortable at gray. And I've always been comfortable with gray. And so I was drawn to focusing on making sure that patients and their families were getting care at the right time and in the right place and for what they wanted. And I think that was what was meaningful for me. And so that's why I've been on this path for many years, over 20 years. And I find myself more inspired every day by the team that I work with, because they are doing work that other people don't feel so comfortable with. And they do it with such grace and expertise. And I cannot begin to tell you how many times I have families come to me and say, these people are angels, and I wish I had known about hospice sooner. Yeah. So thank you for letting me be here today. And I'm hopeful that I was able to answer anyone's questions.